door. I call them the hens because they're always clucking.
Oh, yeah.
All right, here we go.
Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
It's time for episode 8. My name is Sean, and my partner in crime is, you know him, you love him, Dietrich, aka Skinny Medic. So, what are we talking about today, man?
So we've been talking about trauma for a while. We went through the March algorithm. We've been hitting the heavy, like nasty trauma. So I thought this episode we'd kind of shift gears and kind of talk about some medical emergencies and just kind of look at like the 50,000 foot view of some medical emergencies that we might run across.
I love it. That's actually really, really helpful for a ton of people, I think. Let's start out breathing.
So yeah, I mean, this is a major problem that you can run into, whether you're at work or if you're at, wherever. Pollen season, we were just talking about a few minutes ago off the air, is right in the middle of us right now. So we're getting killed with asthma problems and different types of breathing problems. So you can have asthma, COPD, congestive heart failures, but there's a number of things that can happen. But probably one of the most things we see often is asthma, where these maybe it's a child who has asthma, maybe it's an adult who has asthma, but they have constriction of their lungs, the bronchioles, which is where the air pockets are, and they have constriction there, so they have a hard time getting air out. So they get some wheezing noises in their chest. So they have an inhaler, and we can help them or use their inhaler. It's going to be prescribed to them and things like that, but we can actually help them use it, and it's going to help them while EMS and first responders are on the way.
Makes sense. So, what are some of the symptoms that someone would see if they're not too familiar with it when we're talking about like the asthma and stuff?
So they're going to be shorter breath. They're going to appear shorter breath, probably not talking nearly as fast as you and I talk, but they're going to be having some trouble breathing. Maybe they're speaking in short, 1 to 2 word sentences. They're going to be leaning forward. They might be sweating a little bit. But if you do have a stethoscope in your kit, you can listen to their lungs and listen to, right around the shoulders and right around where the diaphragm is supposed to be, maybe a little bit above that. But you can hear that wheezing noise. It'll sound like a whistle going off. Maybe it's when they inhale, maybe it's when they exhale, but you can hear the whistling noises in there.
All right. So for us civilian responders, what if they don't have an inhaler or it's just kind of some random asthma attack or something like that? Or is there anything that we can really do besides help them apply meds in some way?
Just try to keep them calm, trying to coax them through taking some deep breaths and try to get them calm because they're panicking, obviously, because they can't grab air. So they feel like they're suffocating. So just keeping them calm, hopefully when first responders get there, they're going to bring oxygen and stuff like that. And unfortunately, you typically need a prescription for that. So you can't just carry that around the average civilian. So if we can keep them calm and maybe remove them out of the environment that got them excited, or, there's a problem. Maybe they're having an asthma attack because of the grass or whatever's outside. So let's remove them from the environment and try to get them calm.
Okay. Can this be fatal?
It can be, yeah. I mean, it can be. They can completely shut down where they're not moving any air, and then they stop breathing, and then that, of course, is never a good thing.
Yeah, definitely. Okay, cool. So that's some breathing problems that we could have. What's next?
So, like I said, we covered the breathing problems, and with asthma, we talked about the wheezing. With congestive heart failure, that can be some fluid building up. You can also get pneumonia with that. Typically, with congestive heart failure, you get some buildup because your heart's just not pumping quite as well. So you get a little bit of fluid built up in your lungs. Most of the time, these patients take medications to control it, so they're fine. You can get pneumonia there as well. You're probably going to run a fever with that. And then COPD is another one we see as well. You can get patients who smoked a little too much when they were growing up, Maybe there's still smoke. Happens all the time. People are on oxygen, they're still smoking a pack away of
No.
cigarettes there, and they catch themselves on fire, catch the house on fire, which is never a good thing. But really, that asthma patient is one we can get the inhalers for, and we can help them the most. The next subject I got written down in the notes is choking.
Yeah. So, I mean, choking, this happened. Like, raise your hand if you've never choked on food or something. My hand did not go up for those that are listening, because I have, and it freaked me out. So, the one that is the most idiotic, but also the one that I can remember no matter what. I was like maybe fifth grade. I was at a taekwondo class, and for some reason, I had a quarter in my mouth. And like I have no idea. I was like I was chewing on a quarter, and it went down and just completely blocked it. I was able to just freak out a little bit and get it to remove. But that was the time when I was like, holy moly, choking is real. And I do not put crap in my mouth ever anymore because of that memory is so strong. Just ridiculous. But what can people choke on?
I mean, it could be anything like a foreign object in their mouth, like we're talking about, like the coin or a piece of food. Little kids choke quite often just because of the way their airway is shaped. It's kind of flipped the opposite way we are, and it is to protect it. So it's kind of narrow at the top, where ours is wider at the top and closed at the bottom. Theirs kind of is reversed. So typically, whatever's blocking a child's airway is just sitting right on top, so we can clear it pretty easy. But for them, it could be the formula, it could be some kind of just small toy they put in their mouth. But it can be anything that blocks the airway, and that's a scary feeling. You're going to hit the panic button instantly. And typically, people have like that universal sign where they put both their hands around their throat. It's what we do automatically. We just know that we're choking in our arms, and our hands go really around our throat because you can't talk. And the important thing to remember with choking is that if they're coughing or they're talking, their airway is not obstructed. They might be partially obstructed. It might be kind of closed off a little bit, but they're still functioning. They can still talk. They can still move air. If they're coughing, their body is trying to fix it.
Yeah. I will say that, I mean, I've seen adults choke. I was at lunch with some coworkers a few years ago, and we were having some barbecue, and just looked over at him and saw his eyes watering real bad. He was literally choking on a piece of meat. I stood up to start to walk over, as did we all, and suddenly he was able to get it up and get it all out into a cup. But people, like, they panic when they're choking. There is a huge panic element to that.
I one of my best memories was we got called out to a choke in EMS, and we just happened to be right around the corner. So we go in there, 911's telling us they're actively choking. I pushed open the door of the house, and I see this little lady. She's like 150 years old. She's choking. She's blue. She's got her hands around her throat. So I come back behind her and did the Heimlich maneuver on her, and like I swear I almost picked her off the ground when I did it. And piece of food come flying out of her mouth, and she turned around and she cussed me out and like flipped out on me. She said I almost broke her back, and she was so mad at me. And I was like, ma'am, I just stopped you from choking. And she was like, but your fist almost touched my spine. She was so angry at me, and I was like, all right, ma'am, have a good day.
Yeah.
We just walked out. I'm like, totally saved your life, chick, but you're 150 years old. You can be ornery if you want to. So we just laughed. Like, there's nothing we can do about it.
Right, exactly. That is so weird to me. I'm like, literally, she would have died had you not gotten there.
I'm like, we just happened to be right around the corner. We had a quick response. I'm like, if we would have been anywhere else, you probably would have died. I'm like, but appreciate it. No problem. Have a good day, ma'am.
So for obstructions like that, you mentioned Heimlich maneuver. Can you walk us through the Heimlich maneuver, how to apply it, what the applications of it are, et cetera?
Yeah, the Heimlich maneuver, and this is where we'll talk about CPR in a second too. We've talked about getting training just about every episode, and I think this is where people definitely need to take a CPR class, spend a couple hours, and get some good hands-on training. And it's pretty reasonably priced for a CPR class. So get some training and get some hands-on training for this. You can hear us talk about it, but locating these spots on the mannequin and doing CPR and stuff like that, it's super important, especially with little kids. So I think that's important for get training. So the Heimlich maneuver is, we try to get behind the patient, and your fist, you ball it up and you put the other fist your hand on top, and basically between the belly button and the rib cage is you put it there and you drive up as hard as you can into the diaphragm, like rib cage area, almost like you want to touch your spinal cord. And you're forcing that air to come up and the diaphragm and everything to come up to the chest cavity, kind of change the air pressure to hope that it dislodges it. Well, that's for an adult. If we have someone who's maybe too big, they're a little on the hefty side, or maybe they're pregnant and you can't get your arms around them, then you just put it around the chest and you just squeeze behind them as quick as you can to kind of do the best you can. And that's, if a patient is still alert. Obviously they're not talking to us anymore. They're not coughing anymore. So we know their airway's completely obstructed when we do this. Because if you do this on someone that is not choking, they're probably going to puke on you. And I'm a sympathetic puker, so we don't want that. But then, if they, on a baby, it's a little bit different. So we can turn them and put their head like towards the ground, let gravity help you out. And you basically slap them on the back 5 times. And it's a good firm pop on the back. And then you rotate them over and you do 5 chest compressions. You keep going back and forth until the airway is cleared. And then if they do go unconscious, then, we're going to start CPR with just chest compressions. And, I don't like to do mouth to mouth. That's nasty. That's gross. So, chest compressions only. If you've taken a CPR class a while back, then you probably have been taught, the blind finger sweep. And we've kind of gotten away from that. But, we do want to look in the mouth to see if you've dislodged whatever's in there. And then you can kind of put them in a recovery position or log roll them and get the food or whatever's out of the airway.
Yeah, definitely. I was just going to ask about the finger thing because, I'm not losing a finger.
No, I don't either. Like, I'm not sticking my finger down in there. If I can see it, then we talked about the recovery position, but my finger's not going down in there.
Yeah, not even a little bit. Okay, so that's Heimlich maneuver. That makes sense. I don't think I can think of any questions people might have. And then CPR, do you want to cover that in greater detail, or do you think that was enough?
Yeah, I think that's enough. I think we can probably come back to that, if we want to in a later episode. We just, like this episode, I was thinking maybe we just kind of give a quick, broad view of all the medical emergencies. And then later on, we'll just kind of dive more into them.
Perfect. All right. So what is next?
So I have allergic reactions in my next set of notes here.
And then, what is an allergic reaction and how the heck do we even respond to it?
So this could be from food allergies. This can be from environmental, maybe like bees or whatever kind of insect bites they get. And you can have, allergic reaction even from the pollen outside, like we've been talking about. Like everything's yellow right now, so your nose running is an allergic reaction to the pollen going up in your nose. So your eyes watering, all that stuff, that's an allergic reaction. But you could have this from food. I know people who unfortunately are allergic to shrimp. Some people are allergic to peanut butter. So it could be a food allergy. It could be you get stung by a bee. And the scary thing is with this, you get stung by a bee one time and you're like, okay, that wasn't a big deal. And then the next time you get stung, your body freaks out. And now you're showing worse signs and symptoms of allergic reaction. So we just never know what our body's going to, how it's going to react to these problems.
Yeah, 100%. And especially you mentioned like pollen and stuff, even that can really be serious. Latex gloves, there's so many, everyone's allergic to everything these days. And
right.
It is a big problem. Which I guess brings us to what do we do about it?
So what if you got allergic reactions, or you have potential to go into anaphylactic shock? We'll talk about that in a few minutes. Your doctor can prescribe you an EpiPen. These things can be kind of expensive at the moment. Hopefully the price is going to come down soon. But EpiPen is a big giant plastic that has a big needle on it, and it carries a little bit of epi in there, and has a huge needle that we can stab to someone's leg. We help them do it. But it drives this big old needle into their leg, and it puts a little bit of epi, which is adrenaline, into their bloodstream. And so what the epi is going to do is it's going to make the blood vessels smaller, and it's going to open up the lungs. So it kind of helps us during this shock situation. But just as important that if you are helping them, don't put your thumb on the end of it, because I've seen people who have put their thumb on the end of it, and as they drive it into the patient's leg, it's upside down.
Oh.
And so that needle that was supposed to go in the patient's leg is now inserted into your thumb. So every time I teach people, I'm like, don't put your thumb over the back of it, because you just never know. In a moment of panic, you're like, oh yeah, we got this EpiPen, I'm so excited to use it. And you stab your best friend with it. And now you've got a needle in your finger. Now you have the epi going into your thumb.
Yeah. Well, it's not going to hurt you necessarily, but it's definitely going to be a rough afternoon.
Yeah, that needle is a few inches long, so it's not going to feel the greatest. So, like I said, typically it's not going to, you're just going to feel jacked up a little bit, maybe feel a little anxious, stuff like that. Typically, unless you have some heart problems, but that's not a huge deal. We can fix it, but just be careful when you go to use it. And so hopefully, it's obviously they have an EpiPen. Sometimes they even carry 2 EpiPens with them.
Makes a lot of sense. And I know a lot of people who have allergies, but would you recommend maybe a civilian medical person, someone who's interested, carries an IFAK every day to have an EpiPen in there?
So not typically, because you do have to have a prescription for it. So you're gonna have to tell, their doctor that, you know, you have allergies, stuff like that. So if the person is having an allergic reaction, and then we can use theirs. We can kind of assist them using theirs. They've been prescribed for it. But if we don't have an EpiPen, say like I would use a bee sting, for example. If they got stung by a bee and they're having an allergic reaction, well, then we can look around for the stinger, stuff like that, and you can take a credit card or take an ID like that, and you kind of scrape the stinger off. You don't want to squeeze it, because if you squeeze the stinger, then you can put more poison into the body. But if you kind of scrape it off the skin, then it kind of stops the poison from going to the body, so it's going to help them. So kind of the same thing we talked about before. If whatever's going on, let's remove them from that environment. Maybe we need to wash them off. Whatever's causing the allergic reaction, let's get it off of them. Unless it's a food, then that's a problem. I know of a young person who's allergic to peanut butter, and like they're severely allergic to peanut butter. So if they're in the same room with it, they have allergic reaction.
Right.
So it can be a serious situation.
Definitely. I want to talk about all the symptoms of this, but I think before we do that, I want to move to anaphylactic shock, talk about what that is. Then we'll talk about the symptoms that are between them and how we can recognize these things, how we know the difference between the two.
Yeah, I think so. So allergic reaction is just kind of, maybe it's a localized reaction. Maybe you get some itching, they kind of get some, maybe the eyes watering, nose running, stuff like that. But anaphylactic shock is where it becomes life threatening. This is where maybe they have a high heart rate, they're gonna have a low blood pressure. They're in shock, as the name presents there. So these patients are going to have like chest pain, shortness of breath. They're going to be in bad shape. So just, allergic reaction, just kind of the mild side. And then you jump the fence over to anaphylaxis. We're like, holy crap, this patient could die if they don't get an EpiPen. So kind of that catch-22 there.
Yeah, that's tough. All right. So what are some of the things that we as an everyday person can observe, and how do we tell the difference? Besides being localized and that.
Yeah, so they're gonna have some itchy. Maybe they get some hives on their skin, which is like the red spots all over their skin.
Mhm.
They're gonna have, maybe the rash we talked about, the hives, itchy, watery eyes. Their nose is running, sneezing. Maybe they're coughing because the airway is constricting. That would be more towards like anaphylaxis reaction. Leaning towards more of the anaphylactic shock. Then they're having chest pain, they're having shortness of breath, maybe they're coughing because their throat is closing up, and then they have a high heart rate. We talked about that under circulation or March algorithm, checking for a pulse. That radial pulse is going to be probably greater than 100, and then their blood pressure is going to be low. So I don't, less than 100 systolic. How to give a number for that one, but it just depends on what they may have, what their normal blood pressure is. It's going to be lower than that.
Yeah.
Maybe their heart rates, their respiratory rates a little bit higher because they're trying to compensate for everything going on. But hopefully these patients do have an EpiPen that you can use. And then first responders will definitely have it. So, trying to keep this patient calm. And we talked about, and looking for that reaction, see if we can stop the reaction that's causing the problem.
Definitely. And can also be fatal like quickly. Would you say, I've actually heard a bunch of people ask this question for anaphylactic shock, if you see them in their airway starting to close down, MPA or OPA useful, or just nah?
Nah, I don't think so. For me, I just don't think that where it's closing up is around the larynx typically, which is the voice box. And the MPAs and OPAs don't reach down there far enough where it's going to occlude. So I think you're just causing more problems. I think you're just kind of working on something that's not going to be very effective. So if EMS gets there, then if this goes south really quick, then they can take a scalpel and cut the patient's airway open and put a breathing tube down past where it's closed off. So obviously I wouldn't recommend that for your average first responder. You see it in the movies, they pull out the MacGyver pin and they stab someone in the throat, and all of a sudden they're alive and they're breathing well. But probably wouldn't recommend that for the civilians, because you better be dang sure you're doing it and not want to get sued for it.
No, there's a lot of nerves. The cricothyroidotomy, and every time I see someone carrying a scalpel in their med kit, I'm like, dude, what is that for? And generally it's for a crike, and I'm like, no, stop, don't do it.
Yeah, don't do it. Like, it's just, I mean, it sucks to watching the patient, die, honestly, but there's so much liability there. Like, I don't know. So, but yeah, I've been in EMS for 16, going on 17 years now. I've trained on cadavers, mannequins, all that stuff. And unfortunately, I guess, fortunately or unfortunately, I'm not sure you want to say that, but I've never had to cut someone's throat.
Yeah, absolutely. It's we even talked about this before in airway, and it's something that not a whole lot of people do. And generally, in a hospital or something, they'll get the guy who's done it, the guy or the lady who's done it before, and they'll be the one that is the go to when that needs to happen.
Exactly. Like the military side, those guys have done it, and you will see it sometimes in the hospital setting. But like I said, typically, you're right. Like they're gonna go, who's done one before? Oh, you've done it. Come here. You're gonna do this one. And so everybody's scared to do it, which is obviously why. And I've always said, like, for me, in my mind, like, it's gonna be like 2 o'clock in the morning in the rain in the back of a car. I'm gonna be cutting on somebody's throat. Like, that's just the way my luck runs. So hopefully I never do it. But at the time, we'll do it because the patient's either going to die or you cut their throat. So we'll do it, if I have to. But so far, haven't had to do it.
That's good, man. So is that it for allergic reactions?
Yeah, I think so.
All right, cool. So what comes next? Looks like heart attack.
Yeah, heart attack. So this is when it often gets confused between cardiac arrest and heart attack. So we'll talk about that in a few minutes. But that's kind of funny when you hear people say, they survived it and like get to talking to them. Actually, what they had was a MI, which is a heart attack. So someone starts having chest pain, and maybe it's radiating down their arm, maybe it's in their jaw, maybe they're having trouble breathing, maybe they're nauseated, they can start pouring sweat. These patients probably need to go to the hospital and get some blood work done. They're probably going to buy themselves a cath to see. Maybe it's just exploratory cath, but these patients need to go to the hospital. And I think in a later episode, we'll talk about a sample history, which kind of helps you get some medical information, signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to. And that's something we can ask our medical patients to kind of get better idea what's going on. But we'll talk about that in a different episode to kind of make people keep tuning into us. But someone's having a heart attack, they're having chest pain. One of the things that we can do before EMS gets there is give them some aspirin. And this will absolutely make a huge difference down the road for them.
Yeah, and why is that?
So the aspirin, it basically takes the little edges off the clots and it smooths it over. So the heart, the body realizes there's a problem in the heart, and it starts sending these clots to it, and it starts blocking the coronary arteries. The coronary arteries are little arteries run outside the heart to kind of feed the heart. So when blood starts getting obstructed from there, then it starts dying, and the body doesn't know how to say my left ventricle is dying. It doesn't know how to tell the brain that. So that's where we just get like this elephant sitting on our chest. It's the left arm pain, the jaw pain. The body doesn't know what's going on. It just knows something bad's going on. It starts sort of freaking out. So that's where we can give them aspirin. Typically, we give them 81 milligrams. An adult dose is 325. If all you have is an adult dose, it's fine. But let them chew it up, and they can go and chew it up and take it. Now, the adult aspirin is 325, and it tastes terrible if you have to chew it up. We've got the baby aspirin. You can let them chew up 81 milligrams is what they take on a daily basis typically. And then the 325 is when we give them an emergency. So we can have them chew it up, and it's going to help. And it takes a while to get into the bloodstream, so we want to give that pretty quick. But you can absolutely help them. The only thing we kind of warn people on is about people who've got like GI issues and stuff like that. But I would rather deal with the GI issues later than deal with the heart attack problem that's getting worse.
Yeah, definitely. So that was the heart attack and the MI. What about cardiac arrest?
So a heart attack is the occlusion of a coronary artery or a spasm. It can be a little spasm, but it's an occlusion of coronary artery. And then the cardiac arrest is actually when your heart stops beating. Technically, you are dead. It may not be beating at all. Maybe it's just in there quivering, but you are dead. You're not breathing. There's no pulse, and you need CPR. So with a heart attack, you need some medicines. You need a heart cath. They'll put a stent in. With cardiac arrest, you need great quality CPR, and you're probably going to have a heart attack anyway. It's probably what caused you to go into cardiac arrest because we've eaten McDonald's for the last 30 years and we have high blood pressure, diabetes, cholesterol, all this good stuff. But cardiac arrest means you're dead and you need CPR. Heart attack means you are still alive and you just need a cardiac stent.
Pretty crazy and pretty scary stuff, but really common these days.
It is. It's super common. And then unfortunately, the survival rate for cardiac arrest is almost like it's some areas it's 10% out of hospital cardiac arrest survive, and that's a really crappy number. And unfortunately, it's because every minute that you're in cardiac arrest, meaning your heart's not beating, your chances of survivability is crashing, typically by like 10% for every minute. So if the average response time is even 7 or 8 minutes for first responders, you're in the hole before you ever get started on these patients. So witness cardiac arrest means you watch someone fall and you immediately start chest compressions. Those absolutely have the best chance of survival.
Makes sense. And you did mention good quality CPR being very important. Is that, would you say, one of the factors that has that survival rate so low is poorly applied CPR?
Absolutely. I mean, people just don't want to do CPR, and I get it. Maybe they've been married to their spouse for 60 years, and this is a very traumatic event, and they don't want to do chest compressions. Or maybe it's a grandchild that's fallen into a swimming pool, and now they pulled them out, and they don't want to start chest compressions because it's their grandchild. They're too upset, or it's a bystander. They don't know what's going on. That bystander effect kind of kicks in there.
Mhm.
But absolutely, we've had much better outcomes on patients who have fallen in a public place and someone steps up, takes charge, and starts CPR. And you don't even have to do mouth to mouth anymore, really. I mean, we've kind of proven that you don't really, there's enough oxygen going around that's sitting there in the blood. We just got to get going round and round. If we do good quality chest compressions, that we can help this patient. So you don't have to worry about doing mouth to mouth. You just push on their chest somewhere between about 120 beats a minute, 110, 120 beats a minute. If you sing Another One Bites the Dust, just don't sing it out loud, just sing it to your head. You really get some people looking at you when you start singing, Another One Bites the Dust out loud at the mall. Like that's kind of weird. But that's about the right rhythm that you want to be at.
Staying Alive is a much more cheery song.
So we do Staying Alive for kids and Another One Bites the Dust for adults. It's
Uh,
like, because you don't want to be doing chest compressions on a kid, and you're like, "Oh, another one bites the dust."
right.
But if it's an 80-year-old at a nursing home, you're like, "Oh yeah, another one bites the dust." So it just
Yeah,
kind
that's
of depends
fair.
on where you're at.
That's fair. And I think we could do a whole episode about CPR, like really talking about, that correct and well performed CPR.
Absolutely. There again, I think taking a class, and there's even some good data that shows after you take a CPR class, you sit through a few hours, the next week you're still solid on it. 6 months later, you're not so solid on it. And a year later, you're really crappy at it. So taking it again and again and again is super important.
Yeah, I think maybe I'll go take one of my local CPR classes. I am CPR certified, but it's been a while. I need a refresher, so maybe I'll go take one, and then we'll talk about it right after.
Yeah, that'd be awesome. I just got some new mannequins in that provide feedback to the person doing CPR. Like it clicks when you're going deep enough, and it has red and green lights, so knowing your rate's good. So the person can do CPR for 2 minutes, which is a while. You'll get smoked, but you give them that quick feedback. So I like that. The rescuer can see what they're doing right, what they're doing wrong. But yeah, we could absolutely talk about CPR for a full 45 minutes, hour long.
All right, that sounds cool. Hold on one sec. Come in. Hello? Yeah, hold on one sec. Write this down. 29. Sorry.
Totally ruined our streak.
I know. Let's see. Okay, I wrote it down so the editor will be able to take that out. Okay, cool. And I think that's where we were. We can move on to the next one. So
Yeah.
I'll bring us into it. Okay, so I think we covered that. We have a plan going forward for CPR. Excuse me. Jeez, that's a disaster. Hold on, let me tell her when I go back in.
Smoker's hack.
Apparently, except I've never ever smoked once. Okay, so I think that has us covering the heart attack and cardiac arrest and all that good stuff. We'll cover CPR in detail later. What's next?
So another common emergency that I think we see a lot is diabetes. You can have your blood sugar. Your body's kind of a freaky thing. Like it needs sugar, but it doesn't want too much, and it can't have enough. Like it's kind of this fine line where it wants you to be at. So people get diabetes. Maybe it's an adult onset. Maybe it's a child. Maybe it's when they're pregnant. You can get diabetes. But they have to really, watch their diet, watch their exercise. If they get sick, it can jack up their blood sugar. So you can have it. So maybe they just take a pill, or maybe they take insulin. Kind of depends on where their diabetes is at. But it's basically their pancreas is not pushing out enough insulin to control their blood sugar. So you have to take some external medicine to kind of help do that. So you can have two things. You can have hyperglycemia, which is high blood sugar, and that typically takes a while to develop. Someone's been sick for a few days, they've been vomiting, they haven't, maybe they didn't because they just quit taking the medicine for whatever reason, and their sugar slowly starts to climb up, and then it's, our typical is, around 120 is what they'll check on their BGL monitor, where they kind of prick their finger and they can kind of put their skin to it, and it'll tell them what their blood sugar is. But it starts climbing up. Maybe it's 800-900. I've seen it like 1,000 or 1,200, and by that time they're unconscious, and they're in really bad shape. They go diabetic coma from it being too high. But I've been on scenes before where the cops think someone's drunk, and they're like, "I think this guy's drunk." And you get there and you kind of smell that fruity odor on his breath, and you're like, "I don't know." And you check his blood sugar, and his blood sugar is 550. You're like, I think he's just having a diabetic problem. Like he's not drunk. And so what that fruity smell is the body's trying to get rid of the sugar. So it's weird, but the sugar will actually come out their breath. You can smell it.
Is that ketosis?
Yes.
Okay.
And then you can pee. You start peeing it off too. Like you just start peeing like crazy because your body's trying to flush it out. So you'll get ketones in their bloodstream as well. So, we typically can't carry a BGL monitor around as civilians, but maybe you look for a bracelet that says diabetic on it. Maybe you're looking for diabetic supplies, and just be careful because they may have syringes in there, and that can be confused with some other things that require insulin or require needles, but that's a whole other story. But just having those, look around for the bracelets or necklace, something like that, it says they're diabetic. The other problem that we can fix is low blood sugar, hypoglycemia, and this is where it starts to fall. And typically this is very quick. Like you're talking to a friend, they're just fine, and all of a sudden they start sweating, and they're like, what day of the week is it? Where am I? Who are you? They get really super confused, and it's because their blood sugars drop. Maybe it's 50 or 60 or even 20. It drops very quickly. So we can actually help these patients as long as they're able to swallow. We can give them some stuff to help bring that sugar up. Now, I like to see like cake icing in your first aid kit. We can do that. Don't get the lemon flavor. Lemon flavor is awful.
Yeah.
But get some good tasting, and then you can even take, if you had orange juice, you can just pour some sugar, like super sweet orange juice, stir it up, and let them drink it, and that's going to help bring their sugar up. Now it'll come up for a little bit because that's a simple sugar, and the body breaks it down very quickly. Then we can get them some good food, like get them some good Southern fried chicken, some good Southern food, and that'll help maintain their sugar, and then you kind of go from there. But that goes back to that altered mental status we kind of talked about with head injuries on the last episode. You got to kind of figure out what's causing them to go honor this altered mental status. So you kind of have to do a little bit of a work to it.
Makes a lot of sense. And this is probably pretty common in today's society, right?
It is. I mean, I've joked before, like I'm down here in the South, so we're in the bacon belt. So everybody has diabetes, high cholesterol, high blood pressure, stuff like that. So that's one of the first things, we'll see someone older. It's, you see they're pouring sweat, they're not conscious. You're like, let's put on some oxygen, clear the airway, and let's check a blood sugar. Like, it's just one of those first things you start rolling through just to kind of rule it out. So,
That
and
makes
if
a
their
lot of
sugar's low, then we can fix that. If you're like, oh crap, their sugar's good, let's figure out something else. So you kind of start ruling things out, but always just quick check a blood sugar.
makes a lot of sense. All right, cool. I think that's how to recognize it, how to help with the stuff that we can actually help with. So let's move on to the next one, which is a scary one.
Yeah, a stroke. So this kind of goes back to like the heart attack. I mean, instead of having a clot now in our heart where we had a heart attack, this is a clot in the brain. So this can be very scary. And this can happen in a moment's notice. You're talking to someone at lunch and all of a sudden they can't move one of their arms, they can't move one of their legs. Maybe their face actually starts to droop down. You'll see like the eye, the mouth, the corner of the mouth, everything just starts to droop down. Like there's no muscle tension there. Maybe they slur their words, they can't get the words out. Maybe they're just not able to repeat simple phrases. Like we talk about can't teach an old dog new tricks. And so I'll ask the patient, hey, repeat after me, can't teach an old dog new tricks. And they can't say it. And I can barely say it, and I'm not having a stroke. But they just can't get their words to function. And a lot of times these patients know what's going on. Like they know they can't move their mouth. They know they can't move their left arm. And they get super frustrated. But recognizing the signs and symptoms of these strokes is important because we've got to get them to the hospital. They need they give them some medicine. They can give them high dose aspirin, but they also have some other medicines that's basically like a clot buster that goes in there. They give it IV, and it breaks open that clot and gets blood flow back into the brain. But we got to get them to the hospital to get a CT scan done. It was just a scan of the head to kind of see what's going on. Because what they'll do is they'll rush you to the hospital, and then they will put you in a scanner, and they will look for a head bleed. We talked about that with head injuries. So if we see blood on the brain, we obviously wouldn't want to give a clot buster to that because it's going to cause the bleeding to go worse.
Mm-hmm.
So if they do the scan and they don't see any blood and you're still having stroke-like symptoms, and it's within the time frame, these are very time sensitive. Typically it's 4 to 6 hours. Some hospitals we can go 24 hours. So it just kind of depends on if they're a stroke center or not, and that's getting a little complicated. But they are time sensitive. They'll look at it and go, all right, this patient doesn't have a bleed. They're still having strokes. The stroke symptoms started 2 hours ago. Let's give the clot buster. And they'll give it, and boom, and hopefully the patient's okay. But the main thing to think about this is the signs and symptoms of a stroke, which would be that the deficits, the speech, the confusion, and then knowing this is time sensitive. So we always ask the family or bystanders or whoever, what time did it start? Like, I need to know, were you watching the 12 o'clock news? Were you watching Days of Our Lives at 1 o'clock? What were you doing? Were you watching Ellen at 4 o'clock? Whatever. Like, I need to know what time it was. And it's bad, but a lot of times these patients they went to bed last night, they were fine, and now it's 8 o'clock in the morning, we woke up 12 hours later and they've had a stroke, and we don't know when those symptoms started. So it gets a little tricky there. But knowing the time frame is super important on these strokes.
Definitely. And yeah, absolutely, get them next level of care ASAP. If first responders can't get there, get them there.
Exactly.
All right. So seizures, another kind of freaky thing that can come out of the blue and can be caused by so many things.
Yep. And seizures can be super scary for people who've never seen one before. I mean, you have a child who has a fever, they will seize. And typically for us as first responders, the parents are more of a patient than the child who just had a seizure because their fever spiked up. They've been running a low-grade fever for a couple of days, and all of a sudden it spikes up to 103, 104, 105, and the body's like, holy crap, this sucks. And it starts to seize. And then their fever breaks, and the body quits seizing, and they're fine. They will probably never have another seizure the rest of their life. But they can be scary. And then some people just have seizure disorder and they have seizures, so they take medication for it. There's even some cool things where now, like, they're putting these devices in someone's brain, and you can kind of rub a magnet on it and it will stop them from seizing, which is pretty cool. But these are scary because even maybe sometimes they just kind of shake one arm, or they're kind of localized, maybe they kind of stare off. But for me, like the grand mal, like the seizures where they're just completely clenched up, their arms are clenched, their legs are clenched, and they're just shaking all over the place, those can be scary for bystanders.
Yeah, absolutely. It's so I was over at my son's house, and His wife's cousin was there, I believe, and my son and I were sitting downstairs and kind of heard a little ruckus from upstairs. And apparently, a little girl had just kind of eyes rolled back in her head, tiny, tiny little seizure, muscle contraction and stuff. And yeah, the mom was absolutely freaking out and still don't even know what happened. Kids are just weird sometimes, but they did take her to urgent care because I was like, I don't see anything. Everything looks fine. Her vitals are okay, but still, there's got to be some kind of explanation. And, don't want to take a risk of it being something worse.
Exactly. Hopefully it is something mild that's no big deal they can take care of, but it could be, maybe some more severe going on. So, if we know they're running a fever, they've been sick, snotty nose or sore throat or whatever for a while, we can kind of help, guide them. This is a febrile seizure and kind of calm them down a little bit. But those are the scary ones. The fact like, this patient is not running a fever, what's going on? They don't have a history of seizures. So these patients are going to shake for a little bit. Maybe they get confused afterwards. They can be a little combative just because they don't know what's going on. But the biggest thing to do is protect the patient. If they're flopping around like a fish and there's chairs around, stuff like that, just move everything out of the way. Like, don't try to hold them down. You're not going to be able to stop them. But just move everything out of the way and make sure they can't hurt themselves.
Yeah, 100%. And then in the notes, recovery position. So good for that as well, just in case they do vomit or have any other fluids or anything come up.
Yeah, once they quit shaking, they quit the seizure, roll them over the recovery position. We've talked about that in a previous episode, how to do that. And that protects the airway. And one of the myths I hear a lot is, they can swallow their tongue. And that's absolutely not true. You cannot swallow your tongue. It's attached to the bottom of your jaw. You can't swallow it. So don't stick anything in their mouth. Don't put a bite stick in there. They may bite their tongue. They may have some bleeding. We'll take care of that afterwards. But don't stick anything. Don't stick your finger in there. Don't try to just block their airway. Just let them flop like a fish, and then we get done flopping like a fish. Put them in the recovery position.
Definitely, and get that next level of care ASAP.
Yes, because a lot of times, maybe like little kids, they will carry Valium with them. So, and this is with little kids, they give rectal Valium. So it's the easiest way to get the Valium into the body. And so maybe the parents have that. And the parents typically are super educated on this stuff. If you have a sick kid in general, I always talk to the parents. I'm like, the parents are super educated on what's going on. Hopefully, so if the child does have a history of seizures and they have the rectal Valium, then the parent can assist and do the Valium for you, and you can kind of roll them into recovery position there.
All right. I did not know that rectal Valium is a thing.
It is, yeah, for kids. And it's the easiest way to get access to it, and the absorption rate is good. So you'll see a lot, like at schools and stuff like that, they'll give it.
Interesting. That would make an interesting school day.
Yeah, you don't want to do it in front of your buddies, like, hey, buddy. So they do try to keep the privacy there. But, especially for little small kids, an infant that's seizing, rectal Valium is one of the access points we can use.
All right.
And it's kind of different. Like, it's like, I know this is getting a little awkward, but yeah, like, I don't think anything about giving rectal Valium for an infant. Now, a 35-year-old man, I'm like, no, it's a little weird, bud. But, for little kids, like, you feel bad for them. So you kind of move past it.
100%. And like my kids, we had to do medication via suppository several times as they're so the first time you're like, okay, I hate everything about my life right now, but then by the fourth kid we were like, okay, whatever.
Yeah, you just get used to it, and it's for the better good of the kid.
Yep, 100%. All right, cool. That was a lot of medical emergencies that were non-trauma related or non March or the other stuff that we've been talking about, but a lot of this stuff that we talked about situationally still applies to everything else here. Make sure that you're seen safe, make sure that you have any biological barriers that you need, make sure you understand what the possible threats are. You told the story, I think it was last week, about the diabetic person that you had to fight and that you fought for a little while.
Mm-hmm.
So you got to pay attention to everything that's going on around, understand that we can't get super task focused on one specific thing and that we have to pay attention to everything that's going around, regardless of what this is, regardless of how crazy and scary and whatever else it happens to be.
Right. And for me, like, I think about trauma patients are fairly easy. You just you cut their clothes off, make them trauma naked, you fix the bleeding, you fix holes, and you move on. For me, medical patients are much more difficult because it's a detective game now, because now you got to ask 1,000 questions. And ultimately, they're going to, if you're there helping someone, they're going to tell you one thing. And then when the first responders get there, they're going to tell them a different thing. And then when we get to the hospital, they'll tell the doctor something completely different. So it's just the way it rolls. And so it's kind of detective work, like trying to figure out what's going on with this patient. So you kind of have to dig in and kind of use some investigative work to figure out what's going on.
Definitely. All right. Very cool. Excellent stuff, man. Thank you very much for that. Now, let's move on to our product of the week, which this week you chose Quick Clot Combat Gauze.
Yes. So we kind of covered tourniquets for a little bit. So I was like, hey, let's start kind of talking about this. So for me, Quick Clot Combat Gauze is what I use in my kits. There's some other products that are on the market. We'll talk about those soon. But Combat Gauze, I've used it in the field a couple of times. It's worked great. And it's basically a hemostatic agent. I mean, I guess it is a hemostatic agent, not basically, but it helps us control bleeding in areas that we can't get a tourniquet, or maybe we ran out of tourniquets. But it's going to help us control bleeding.
Yeah, there's the bicycle video of the guy mountain biking. I'm like, that is prime location, injury, everything for some good hemostatic gauze.
Absolutely, that's a great video. I mean, that guy is pouring out blood, and that first responder's got his fist just buried in that dude's pelvis, and
Yep.
it's still bleeding. So, absolutely, good quality wound packing is going to be important there. But the combat gauze can help you tremendously, because if we're using regular gauze, we're just going to hold pressure for like 10 minutes. That's a long time to be holding pressure. But for a combat gauze, you can get the bleeding stopped in as little as 3 minutes.
Yeah, let's talk a little bit about the history. So, I mean, Quick Clot has been around in different forms for a while. The original, I believe, was the granules, which were thermal or thermic, meaning that when activated, they would heat up to pretty hot, right?
Yeah, I mean, that's kind of what, from my understanding too, is that it was a powder form, so they would get this nasty bleeding, and they would just pour this powder down in there, and you would hope that the wind wasn't blowing or the medevac wasn't flying in at that time, because it would just blow all over the place. But you pour it into the wound, and it basically just cauterized the wound, like just burned it. And then they were figuring out these dudes were dying 2 weeks later because of infection from the burns.
Yeah, which is, I mean, definitely not the result that we were looking for there. So they've figured out a different formula, and that is non-thermal. It doesn't generate heat when you use it. Now they've impregnated the gauze with it. So you get to pack that in, get that material in there up against the bleed, so you can keep that pressure on it. But also having that hemostatic agent infused into the gauze helps the blood clot and helps you stop that bleed a heck of a lot faster. There's the thing out there where everyone's like, oh, shellfish allergies, this is terrible for people with shellfish allergies.
Yeah, so shellfish allergy is actually for Celox. The combat gauze is impregnated with kaolin, which is a natural clay, and that's just basically takes the water out of the blood and makes it thicker, which is going to help us with the clotting process.
Yeah, and clots are definitely the key and definitely the important part there. So Quick Clot has kaolin. It is a hemostatic gauze. It's about $45, which is a little bit pricey.
Right, and like I said, unfortunately, sometimes maybe your budget doesn't allow for you to get that, and I get it. It's typically going to expire in about 5 years now. That's a whole another subject about, it just probably doesn't just immediately go bad. It just kind of loses how effective it is over time. But either way, I mean, it's going to be not as effective in 5 years. So that's a big budget item that a lot of people don't have the budget for, and they're just going to run compressed gauze, which is fine with that. But if your budget allows, then I would encourage you to put some combat gauze inside your trauma kit.
Yeah, I 100% agree. I always carry it. I always carry extra gauze as well. But if I need to get it up against that bleed, you can bet that I'm always going to use the Quick Clot first.
Yeah, me too. Like I will run combat gauze as my initial gauze to go into the source, and if I need some backfill, then I'll run compressed gauze, just regular gauze after that.
Yep, 100%. And available at Medical Gear Outfitters.
Yes, sir.
All right, cool. So this show is going to come out after the NRA annual meetings, but I do want to talk about what we're taking individually as medical gear, because clearly people are going to be walking up to you and asking you, what med gear do you have on you?
Yeah, so I thought it was kind of interesting for us to talk about. Just take a few minutes because I was kind of curious what you were taking, because you're flying, correct?
Yep.
Yep. So I'm driving, so you're flying, so you're kind of probably taking a little bit different setup than me. But on me, I will have a Skinny Medic pocket kit in my backpack, which has a cat tourniquet, a pressure bandage, compressed gauze, and gloves. And then I will also have another cat on me as well. So I know all the tourniquet wars going on. I can't get caught without a tourniquet. So I'm
No.
going to have a tourniquet on me. And then we're driving up. So you guys, you be praying for me. I'm driving up with 2 kids and a wife. So probably don't kill each other. But we're driving up. So we're going to have our medical backpack in the van. So it has all of our trauma supplies. It's got some medications in there like Tylenol, ibuprofen, Benadryl, things like that. I've got my blood pressure cuff, things like that. So more of a bigger kit inside my wife's car in case we roll up on a wreck on the way up or we have an emergency ourselves. We're able to take care of it until help gets there. But on me, I'll have some kind of smaller items. But then in the car, we're gonna have some even Band-Aids. That's I'll have some My Little Pony Band-Aids in there for the kids. But we'll just have a bigger kit inside of our car.
Yep. Now for me, I'm flying, so I'm not going to bring any of the basic first aid stuff, but I'm going to have 2 separate things with me. One in my backpack that I take on the plane with me, and that's my full kit that is available at medicalgearoutfitters.com. That's the WLS trauma kit, and it's got multiple tourniquets, chest seals, MPAs, a needle decompression needle. Let's see, tons of gauze, combat gauze, gloves, tape, lights, pretty much everything that I would need based on everything that we've talked about on this show. And it is literally full to bursting in a tearaway pouch. I put that in my backpack. I take it on every plane ride with me wherever I go, but also every single day, just in case I'm away from my backpack, I will have my ankle rig on. And I got that also from Medical Gear Outfitters. I think it's the North American Rescue ankle rig.
It is. Yep.
And in that, I carry a SWAT tee, a cat. I carry MPA and lube, gloves. I've actually taken my compression bandage out since I put the SWAT tee in because it can pull double duty. And let's see what else. MPA, combat gauze, SWAT tee, gloves. I think that's chest seals. I use the Hyphen compact chest seals in there as well. And I think that's about it. So, just much less stuff, but really stuff that covers the exact same gamut. And I'll have that on my ankle every single day. So
hopefully our listeners don't catch us without medical.
If they do, I think that you have to buy them a drink.
Sounds great.
So if they catch me without medical, you have to buy them a drink.
We'll see about that. Let me borrow your credit card.
Okay, no problem. But yeah, I think it's important. And this is a situation. There's a ton of people. I don't like being in places like that, just because it can be more dangerous. Wherever there's a lot of people, there can be a lot of chaos, and that's why I carry medical gear at all these shows that I go to, just because I think it's important. I think it's important every day, just in general, but especially in big crowds where we've got the bystander effect, we've got the ability, or not the ability, but we've just got so many people in a small area that there is a high likelihood of chaos going on. And I don't mean anything terrible. Like I was at the Great American Outdoor Show, and someone accidentally, literally one of the booth people shot a gun on accident into the floor. It didn't hurt anybody, and they were forced to immediately pack up and leave. But man, what if that gun was pointed, a couple degrees in the wrong direction? Then that is a trauma situation, and it's just silly stuff and like that can happen.
Absolutely. And I'm carrying the gear for me. You're carrying the gear for yourself. So everyone else, they need to carry the medical for themselves. So I would encourage you, if you don't carry medical now, start looking at it. You're taking these firearm classes, you're taking pistol classes, you're taking rifle classes. Take some good quality medical classes, trauma classes, and start carrying.
Yeah, 100%. And again, you can go to medicalgearoutfitters.com, use coupon code Civilian Medical for 10% off your order, which is pretty dang awesome. Your prices are really great. In fact, I buy all my medical gear from medicalgearoutfitters.com, and go check it out. Everything that we talk about on this show, I don't think we've talked about one thing that's not available there.
Yes, sir.
So go check that out. Like I said, this is coming out after we get back from NRA. So hopefully we saw you and had time to hang out. Don't forget to check us out, to subscribe to our show, civmedical.com. That's civmedical.com. We'll take you there. Anything else before we get out of here?
No. So looking forward to NRA. Like I said, this is going to come out afterwards. So hopefully we saw you guys. If you're listening to our podcast, we saw you at the meetup on Saturday.
Can't wait. It's going to be awesome.
and subscribe at civmedical.com.